My name is Dr. Antonio Scalfari. I'm the consultant neurologist at Imperial College, and I'm going to debate in favor of the motion that MS can be considered in all cases a primary progressive disease since the onset. These are my disclosures. The current MS classification allows to distinguish different clinical phenotypes, which certainly helps ensuring homogeneity in trials and clinical practice. The classification places particular emphasis on the occurrence of focal, clinical, and radiological inflammatory activity, which allows to distinguish active versus non-active relapse-remitting patients and progressive patients. However, our clinical experience has raised some inconsistencies with this classification. We know that relapse-remitting patients with no ongoing relapses or MRI activity, which is the so-called NIDA2, can still deteriorate and experience a subtle clinical and cognitive worsening. In addition, in this classification, there is a dividing line between relapsing and progressive form, which does not fully reflect the biology of the disease, as mechanisms underlying different disease stages occur concomitantly, irrespective of the clinical manifestation. There is no biological reason for considering primary and secondary progressive MS as two distinct diseases. Pathologically, they share similar features in respect of the extent of the inflammatory infiltrates and the axonal damage, the proportion of slowly expanding lesions, and the extent of cortical demyelination, all processes leading to very similar rate of brain atrophy. Therefore, relapsing and progressive form of MS are very likely to be driven by similar pathological mechanisms. And this is in line with the elegant concept of a unifying disease model, which was originally proposed by Confavreau based on epidemiological observation, which supports the idea of MS being a one-stage disorder with different phenotypes, which are predominantly age-related. From the clinical perspective, primary and secondary progressive MS share a lot of similarities. Most of patients present with a spastic paraparesis. In similar proportion, they experience overlapping relapses, and they accumulate disability at a very similar rate. In addition, progressive MS patients, regardless whether progression is preceded by relapse-remitting phase, they start at a very strikingly similar age. When they start to progress at a very strikingly similar age. And this is supported by solid data, which has been confirmed by several independent studies. The similar age at onset of progression between secondary and primary progressive MS patients suggests that primary progressive MS patients are somehow amputated from the usual relapse-remitting phase. And also, more importantly, suggests that pathological mechanisms underlying progression start much earlier than its clinical onset, and then they become gradually clinically evident, very similarly to what happened to other neurodegenerative disorders such as Parkinson or Alzheimer's disease. We have evidence that there is a prodromal phase to progressive MS, therefore before the onset of clinical progression. Subjects with radiological isolated syndrome can not only develop relapse-remitting MS, but also experience a primary progressive course, which can occur even 10 years after the detection of the radiological isolated syndrome. In addition, both cortical and cortical pathology, focal cortical pathology and brain atrophy, which are the pathological substrate of progression, are known to occur among subjects with risk and in the early stage of relapse-remitting MS. Finally, axonal loss and degeneration can occur in the context of active demyelination since the very early stage of the disease. Therefore, biologically, we know that progressive MS is active since the onset of relapse-remitting MS, but it remains difficult to be detected clinically. Because of the lack of biomarkers, it is challenging in clinics to distinguish pure progression from incomplete recovery from relapses, especially when the relapsing and progressive phase overlap. And George Eber's group addressed the problem of detecting and pinpointing the clinical onset of progressive MS, which is often clouded by ongoing relapses, by focusing on a subgroup of patients with a single demyelinating attack at onset, which was then followed, after a period of stability, by the progressive phase. And this is the so-called single attack progressive phenotype. And because the lack of ongoing relapses in this subgroup, the clinical onset of the SP phase was more easily pinpointed, much earlier than the average SP patient. Indeed, the mean time to SP was just 8.5 years, and the mean EDSS score at onset of progression was 2. Ebers even reported that among some patients, progression could occur also at EDSS 1 because of the an exercise-induced ambulation impairment or because of the occurrence of pyramidal sign on examination. So overall, these observations support the notion that there is an element of progressive disease since the early stage of the relapse-remitting phase. And this has been recently further confirmed in the pooled analysis of the ocrelizumab trial, where it was used a composite score to define progression independent of relapsing activity. The analysis confirmed that in both groups treated with interferon and ocrelizumab, most of the disability accumulation was not related to any ongoing relapse. These were patients which are relatively early in the disease course with a mean disease duration of 6 years. It is impressive such a large proportion of patients in both treatment groups, more than 2/3, experience clinical worsening, disability accumulation, not related to any ongoing relapsing activity, confirming again that there is an element of progressive disease in the early stage of relapse-remitting MS. And interestingly, in line with the Eber study, most of PIRA events were actually driven by worsening of the ambulation. When we look at factors affecting the probability of experiencing PIRA or RAW, relapsing-associated worsening, changes in the whole brain and gray matter volume stands out as the main driver of the progression independent of relapsing activity. In contrast, relapsing-associated worsening was predominantly due to the occurrence of gadolinium-enhancing lesions, as we would expect. And this indicates that distinct underlying pathological mechanisms distinguish PIRA versus RAW events. And these findings are actually in line from observation from a real-world cohort in San Francisco, which confirm that a large proportion of relapsing-remitting patients experience EDSS worsening without any ongoing relapses. They call it the so-called silent progression, which is underpinned by a faster rate to brain atrophy. Here, for instance, I highlighted patients with no relapsing activity, and I compared those with EDSS worsening or without EDSS worsening, and the patients with clinical worsening were clearly distinguished by a much faster rate to brain atrophy. Interestingly, it has been suggested the serofilament level can potentially be a biomarker of progression independent of relapsing activity. And this was initially suggested after a post-hoc analysis of a phase 2 trials assessing the efficacy of HSCT among patients with early aggressive features. After HSCT, all patients were free of any radiological or clinical inflammatory activity, but a third of these patients, 30%, despite the lack of ongoing relapses, experienced EDSS progression. And this subgroup was distinguished by a significantly higher level of serofilament. In line with this observation, a more recent study, which was presented at ECTRIMS from Basilea cohort, confirmed in a much larger cohort the seroneurofilament level can capture and predict PIRA. Patients with higher neurofilament level were certainly more at risk of experiencing EDSS progression, which was not related to any relapsing activity. Among pathological drivers of progressive MS, not only the brain atrophy, but also the focal cortical pathology play an important role. since the early stage of relapse-remitting MS, and probably explain the disability accumulation better than the white matter damage. The extent of the focal cortical pathology at disease onset was shown to be a good predictor of the probability of experiencing a secondary progressive course. Patients with a larger number of cortical lesions at onset enter the secondary progressive phase more rapidly, and overall, the accumulation over time of cortical lesions drives the gradual transition to secondary progressive MS. A recent study demonstrated also the prognostic importance of the so-called smoldering lesions. These lesions tend to expand because of the presence of a rim or microglia inflammation, which contributes to the remyelination failure and to the axonal damage. And the presence of smoldering lesion has been shown to be correlated with a more severe clinical as well as radiological outcome. Other studies highlighted the importance of innate immune cell activation. This was shown previously to occur early in the disease course, even among CIS patients. And in a recent study from Finland, it has been shown to distinguish patients with progression independent of relapsing activity. Here are compared patients with or without progression among those without any relapsing activity, and certainly those with clinical worsening are distinguished by higher microglia activation, both in the normal appearing white matter and as well as perilesionally. Finally, it is known that meningeal inflammation, which is associated with more severe cortical pathology, is also an important potential driver of progressive MS. It remains controversial whether relapses impact on the long-term disease progression, and compelling evidence from natural history study demonstrated a strong association between early relapse frequency and late outcomes. Here, patients are grouped according to the number of relapses during the first 2 years. The group with high early relapse frequency stands out as an outlier, accumulating disability during the secondary progressive phase much more rapidly than the other two groups. And this is in line with MRI studies demonstrated that those patients with a larger accumulation of white matter lesions during the early stage of the disease are certainly more at risk of developing secondary progressive MS in the long term. The pending question is whether the association between the early focal inflammatory activity and the long-term disease course is actually causal or not. And beyond early relapses, evidence suggests that late relapses correlates quite poorly with late outcomes. The predictive effect of relapses diminishes with time, and among progressive MS, the rate of disability accumulation is only very little impacted by the occurrence of overlapping relapses. But overwhelming evidence indicates that age is actually the key and strongest predictive factor of progressive MS. Being older at the onset of the relapse-remitting phase strongly increases the risk of developing a secondary progressive course. Patients older at onset have a shorter duration of the relapse-remitting phase, and overall the probability of becoming progressive increases with age. And most clinicians would agree that progressive MS is very rarely observed at young age. The probability of experiencing a primary progressive course increases with age at onset. In addition, in pediatric MS, the primary progressive phenotype is very rarely observed, and patients eventually develop a secondary progressive course, always in adult life. Therefore, with the exception of few cases, progressive MS is not a disease observed at young age. But age also affects the clinical phenotypes before the onset of progression. By growing older, patients are less likely to experience relapses, as well as gadolinium-enhancing lesions. In addition, the phenotype of relapses changes with age, as older patients are more likely to experience cerebellar or motor symptoms, as well as incomplete recovery from relapses. So overall, younger patients exhibit a more inflammatory phenotypes with more relapses and longer duration of the relapse-remitting phase. Taken together, these evidence allow to outline an age-related progressive MS model. The silent progression starts much before the clinical onset of progressive MS. It is already active during the relapse-remitting phase, and it remains subclinical for a long time, gradually emerging by growing older and becoming clinically evident once an age-related threshold is overcome. And this is likely to be due to exhaustion of brain reserve capacity, secondary to remyelination failure, iron accumulation, and increase of vascular comorbidity. But on top of this neurodegeneration, which starts from the onset and carry on through the entire course of the disease, patients then experience an extremely variable overlapping clinical phenotype, which is accounted for by the individual immune system proactivity, which is age-related. At one extreme of this wide spectrum, we have patients with a disease onset at young age who are destined to experience more inflammatory phenotypes, characterized by longer latency to progression, a higher frequency of relapses. On the opposite side of this spectrum, there are patients who are older in onset who will present with less relapses and shorter duration of the relapse-remitting phase. It is now becoming evident that MS patients experience an accelerated brain aging. Using a brain age paradigm, which is a learning machine technique, we can now calculate on MRI images the brain age of a single patient, and then also calculate the brain PAD score, which is the difference between the brain age and the biological age. And a recent study using Magnis database has demonstrated that MS patients, in comparison to health control, are distinguished by a much higher PAD score since the very beginning of the disease, and the brain PAD score can predict the probability of experiencing EDSS worsening. Therefore, we can hypothesize that MS patients diverge from normal brain aging, probably once they are exposed to the environmental trigger of the disease. And eventually, at the time of conversion from RIS to MS, they will then experience further acceleration of brain aging. So in conclusion, I provided evidence in support of the notion that MS is a single-stage disorder with an underlying progressive course, which occurs since the start, and a highly variable superimposed accumulation of disability, which is due to incomplete recovery from relapses. Progression independent of relapsing activity largely contributes to the accumulation of disability early in the disease course, challenging the current MS phenotypic classification. And finally, pathological process underlying progressive MS clinically emerge by growing older, are driven probably by changes in the whole brain and gray matter, eventually causing accelerated brain aging. Thank you for your attention.